So, good evening, all. Today, without wasting any time, it's 3 minutes are left, but we'll start with the stats workshop. So, what we decided at this workshop is rather than having a predefined pattern, it will be more of kind of an interactive session where you can basically ask whatever questions you want to ask. We have already got around 12 questions online before the workshop started. So, we'll start with that, but feel free to stop anytime and ask question. I'll request everyone to come ahead. Sunil, today. Divya, aa jao, aage aa jao. Come ahead. Yeah. So I'll request now that we have got settled, I'll request Ashay to ask what was the first question which came.
Basically, we have various questions which are there. The first question is about sample size. So what are the essential elements or information required for calculation of a sample size?
So Atanu, the question is, what are the essential elements which are required for calculating a sample size?
Okay. See, for calculating sample size, first things we need to keep it in mind about the study design. So irrespective of that, what things we need, we have to keep on mind that what about our study design, because always sample size calculations depend on the way you are conducting the study, and that how we are going to conduct the study, that is basically nothing but the study design. So broadly, if we know, or if you say any kind of study design in banner of the clinical research, if you say, so three kind of studies, mostly study designs comes mostly, that is cross-sectional study, case control study, and cohort study. But so first thing is the study design need to be defined. Once that is done, then other essential parts are like, that type 1 error, type 2 error. So nobody considers type 1 error and type 2 errors during the sample size calculations, but as an alternative or mirror image of type 1 error and type 2 error is considered as the confidence interval and power of the study. So once commonly we are having a way to consider the power of a study. So I will come one by one ingredient over there. So power of the study. So mostly we consider 80% or 90% power of a study. So it's this power of a study can go up to 100%, and the minimal value of a power of a study could be 0%. But in terms of the different studies been conducted earlier and the way people accept any studies is having power enough, so the conventionally we are having 80% or 90% being considered as adequate power. So if you perform any study, so it is expected that you should consider the power as 80% or 90%. So obviously, if you are having power as a 90%, then the study is much more strengthened, and obviously your sample size is going to be more. So this is the second part, is the power of the study. Third part is this confidence interval, or it's just reverse part of that type 1 error. So anyway, that power is that reverse part of the type 2 error, and type 1 error and reverse part is basically the confidence interval. So if you are having conduct a study with high confidence interval, in that sense, your type 1 error is going to be low. So once you are going to be low type 1 error, that's mean you are going to be strengthening your study by taking more sample size. So this is two part. One thing is the confidence interval more, type 1 error is low, your sample size is more. Your confidence interval is low, I repeat, your confidence interval is high, type 1 error is low, sample size is more. Your confidence interval is low, type 1 error is more, your sample size is going down. So this is the relations stand between confidence interval and type 1 error, and your sample size. So these are the 3 points I mentioned. Now there are few others component need to be calculated or considered while you are calculating the sample size, and those depends on based on again the study objective, the study, how your study design objective is aligned with your to support your goal. So for that, other parts there, I think we can discuss one by one later on. So mostly these 2 parts: study design, 3 parts: study design, power, and type 1 error. Dr. Vijay, I can't hear you.
Okay, so what Dr. Atanu has told us is it will depend upon the study design, and study design can be anything. For example, I'll give you an example like for a preventive study which Dr. Ravikant will be interested, he would want a study design. Let's say that he wants to find the incidence of gallbladder cancer in the Ganges blend. So that would be a cross-sectional study. For that, the sample size calculations will be different. If as a clinician, I want to see, I want to give a drug in gallbladder cancer patients and to see whether it benefits or not benefits, the sample size calculations will be different. But the sample size calculations which we will be largely bored upon 2 parts. That is, one is type 1 error. So what is type 1 error? To simplify, type 1 error was the first error which got discovered in stats when you do sample size calculation. So this is the error which talks about false positive, which means that it stops you from doing a false positive error. So obviously, let's say in a drug, if you're going to falsely say that the drug is useful, then that would mean that the drug would get marketed for that use. It would get it, most of the times it will be expensive also. So you want to avoid false positive results. So that is what the type 1 error is for. Type 2 error actually helps you to decrease the chances of having a false negative. So type 2 is false negative, and that is also known as the power of the study. So when you say 80% power, that 20% chance that that can be a false negative. Okay. When you say 90% power, there's 10% chance that that can be a false negative results. Now, obviously, this combination of type 1 and type 2 error dedicates depends upon the feasibility. Like you would or like to have a 95% power, or you would like to have nearly 100% power, but it's not feasible because, as Dr. Atanu suggested, as the power keeps on increasing, the sample size will become large. And if you want to go to your 100% power, sample size will be very large. So it is not feasible to get such types of sample size, because at the end you want to do the study and complete the study in a stipulated amount of time. And hence type 1 and type 2 error are also dependent upon the feasibility of doing the study. So one thing more I like to add is that whenever we do a study, the sample size calculations is better to get involved with a statistician and needs to be done at the initial phase itself. Like for example, I want to do tomorrow study on some drug Y to be given in head and neck cancer so that it prevents the disease from coming back after doing surgery. Now it's better that when I get this idea, that is the time I do a sample size calculation, because all my discussions with my colleagues about how many years it will take, what would the kind of resources required, both in terms of manpower, time, patient, and money, will actually be dependent upon sample size calculation. So it's always better whenever you get an idea, you run it by a statistician, you get an idea about the sample size that is going to be required. And depending upon that, then you have a discussion with your colleagues whether the idea is feasible or it's not feasible. I'll give you an example of feasibility. Let's say that I'm sitting in Tata Memorial Hospital, which is 40,000 patients per year. And I need a study for which I need a sample size of 400 patients of head and neck cancer in stage 3. We see 12,000 patients of head and neck cancer. In stage 3, we see around 7,000 to 8,000 patients. So it's very feasible to do this study in Tata Memorial Hospital. Let's say that now I am sitting in another center, which is in, let's say, is in Kerala, where head and neck cancer and the tobacco chewing is nearly literally low there. I don't even see 100 cases of head and neck cancer per year. The center is small. Overall, it sees only 2,000 patients of cancer to cumulatively, and only 100 patients are coming. Out of those 100, only 40 patients are of stage 3. Now to recruit 400 patients, it's going to take at least 10 years if I recruit every patient which comes, which is not possible. Every patient is not going to give consent. So which means, so that is where the feasibility question comes into play. And that's the reason why you meet the statistician first and see whether this number which you're going to get is going to be feasible with in your hands or not. Are there any questions on sample size, or we go with the next question which has come?
Or I can give some more point on that in continuation with Dr. Vijay's point. So you nicely mentioned about that type 1 and type 2 error. So let me tell you why it is required to consider the type 1 and type 2 error. Because see, as Dr. Vijay already mentioned that feasibility of a study. See, why you are conducting a study and what is the importance to conduct a study and getting the results. Because every time you conduct a study, we're trying to understand what in reality in this population in large, or in basically based on the results of a study, we are going to generalize the results for entire populations. So that is the fundamental objective for conducting any study. Now it's true that every time you conduct a study, get an results, and based on the results, we are going to generalize that result for entire populations or prescribing that things. So there is a certain chance that whatever results we are producing, that might be some extent wrong. And to address that wrong or mistakes, this type 1 error and type 2 error stand basically to justify that mistakes. How these mistakes can come? Let's say you are getting an inference or results that, okay, my treatment, palliative treatment, or any effective therapeutic treatments is working well. So you are going to take a decision that this is with respect to the existing therapy, this new therapy is working well. So in reality or in general population level, it might be wrong. So it is not effective. Or it may be more effective that you are going to say. So in that way, so results can be merged in two directions. Wrong can be happening in two directions. Either you are saying it is effective, it is not effective. In reality, it is not. It is really not useful or effective, but you are claiming it is effective. Or vice versa, you are saying it is ineffective, but in reality, it is really working. So both the way it can work. So address this both mistakes or errors. This type 1 and type 2 error stands over there. So it's always the hypothetical numeric considerations being taken, and the reasons or definitions Dr. Vijay already mentioned over there. So every study should come with these two components for sample size calculations.
Yeah, Vijay.
Any doubts up till now?
So I just wanted to ask you, because we always say, as you have rightly mentioned, that you have to have a sample size, and you cannot complete, that is incomplete accurate. And I think many of the times we say the drawback of this trial was it was an incomplete accurate. Now the thing is that many times if you are doing an interventional trial, there are two arms, and many of the times we see that there is an exceptional result what you have assumed, and one arm you have to stop because maybe of the toxicity, or other arm is too superior that ethically you cannot offer the first arm. So in that, when you terminate that arm, does that affect really sample size? Or when you do statistical analysis and how to interpret it, that trial means, do you think that can affect the power?
So Atanu, you got the question?
Yeah. So
yeah.
See, as you mentioned that I think you are talking about some prospective trials, right?
So he's talking about a prospective randomized study.
Right,
and
yes.
Two scenarios. One scenario, the experimental arm had a lot of adverse events, hence the study was terminated. Second, which is okay because it had a lot of adverse events, so it doesn't have much implication in practice. The second is actually a scenario in which the experimental arm was too good, and then the DSMB asks you to terminate the study and do an unplanned interim analysis. On the basis of that, it's concluded that the experimental arm is superior. So he wants to know how to interpret these two results.
Right. So, see, whenever you submit your proposal for institutional ethical committee for approval, so they always ask for, particularly for prospective randomized control trial, they would always ask to have the provision for interim analysis or DSMB board declarations or their report. So these interim analysis give us the provisions to conduct a study in between and get the results. And as you mentioned that you are expecting that this experimental arm is very much toxic, so you are not in a positions to continue the trial. So in that sense, definitely the interim analysis would support us and to get the results and get the earlier remarks on that. So based on the interim analysis report, we can stop the trial. And secondly, it might happen that your trial experimental arm is very much superior, so you don't bother to give this existing arm to the patients as a control. So you want to stop the trial. So both the cases, the interim analysis is safe to us, but in terms of the sample size calculation, what is your fundamental reason for this question would be what I guess, that what is the provision for interim analysis? So interim analysis taken care such a way that the power of a study should be untouched. So if you conduct a study, let's say plan a study for 500 patients trial, and you consider that power of a study as 80%. So even if you conduct the interim analysis, your power will remain same. It would be remain as 80% power, but there would be some compromise on the alpha, or that is called alpha spending function. So basically the type 1 part will be compromised. So and that with this less value of alpha or spreaded function of alpha, that is we are going to conduct that interim analysis report. So interim analysis is a byproduct of your entire sample size calculation. So when you are going to calculate the entire sample size, by default you are going to get this interim analysis power, and that's always been mentioned in this report, that what should be the interim analysis power when you can conduct the interim analysis after having what sample size.
Yeah. So well, I'll just draw a diagram and show you how this actually happens practically in a study. Hello, Atanu, I'm audible?
Yeah, audible.
So there are two types of way you can stop a study in between.
But I can see your board, I guess.
Focusing now. Yeah. One is you have a planned interim analysis, and we'll spend next few minutes talking upon planned interim analysis. So I'll give you an example. I'm doing a study which is as 1,000 to 1,500 patients recruitment, and it's a long time the study will go on, and I want to give it a chance that if the experimental arms actually does very well, I want to stop the study for efficacy. It can be opposite also. If the arm is not doing that well, I want to stop the study for something what is called as futility. Futility means even if I recruit the whole sample size, it is not going to be unlikely that the experimental arm is going to become a superior arm. So I'll show you how you do that. There are multiple ways of doing planned interim analysis. So the basic idea is like when you take type 1 error, you put your, as Dr. Atanu rightly pointed out, power remains the same. What changes is your alpha. Let's say that type 1 error we have taken as classically as 5%. And there are multiple methods of doing this. One method is where you actually divide this alpha by the number of interim analysis you are going to plan. Let's say that I am going to plan one interim analysis in between and one final. So I would interpret the result at this value. What does that mean? So simply, let's say that I'm doing a study of 1,000 patients, For the final analysis, I required 800 deaths to be happening for the final analysis. But I wanted to analyze at 400, and I have planned this interim analysis, and my statistician has already given me with this method that, okay, you will do the analysis at 400 events, but then the alpha needs to be, so I would stop the study for efficacy if the alpha or the p-value falls below this levels. This is a very old method and the most, what you could call a rudimentary method. Nowadays, most of the people would use what Dr. Atanu had said was, one is O'Brien-Fleming method. So these are methods, these are statisticians which have given the methods for what is called that how to divide your alpha if you want to do an interim analysis. And there is a group sequential design method. So what happens in this method is, so if you go back to your MBBS days, your p-value actually corresponds to something called Z. Do you remember Z? So if you remember, we used to learn about a Gaussian curve, and this Z is equal to 0, and then the Z value keeps on increasing positively on this side, keeps decreasing on negatively on this side, and there is one value of 1.96 which corresponds to 0.05 p. So there are Z to P tables available. Now why I'm telling you this is, when you look at GS design for interim analysis, you will get a chart like this, in which there will be number of events written here, which will go from 0, because at the start of the study, obviously there will be no events. Events means if your primary endpoint is overall survival, death is an event. If your primary endpoint is progression-free survival, then progression or death before progression is an event. If your primary endpoint is, let's say, larynx preservation rate, so in that, death will be an event. Disease recurrence will be an event. If you had to do, if the patient requires gastrostomy for 2 years or more, that also is an event. If the patient's larynx is dysfunction and requires aspiration, that also is an event. Point is, event is like a big name, and under event you can have multiple, what you could say, events, sub-events kind of thing, which would say that. So we won't fall into that. From 0 to this, and let's say this is 100 when you wanted to do the final year. The Z value will be such that if you see the graphs, it will be like this most of it. Which means if you, let's say we have done planned 3 interim, 1, 2, and the final is here. So higher the Z value, the lower the P is required. So, and this will, don't bother about how the Z will, that your statistician will do. What you need to understand that if at 100, if I am doing this analysis, let's say at 25 events, 50 events, and finally 100 events, there will be a predefined Z value which will be there. If that Z value is, if this Z will translate into a P value, because it's a higher Z value, the P value will be smaller, 0.00030 and then 6. If when I do the analysis at 25 events, if the P comes below that value, then I would say is that the study should be stopped for efficacy. So for example, if let's say at this stage, the P required for 0.006, but I get a P which is 0.008. This looks significant, but you cannot stop the study for efficacy because this is higher than your predetermined yield. Why are we doing this? This has been done because when you do a small sample size, 1 or 2 events on this side or that side can sway your results. So you want to be very sure that when you're taking decision on a small sample size, the results are absolutely significant. Okay. Now, as I brought this, we are now talking about only our planned interim analysis. I'll come to unplanned interim analysis after this. There will be a Z curve like this also. Now this Z actually is for futility. So for example, you do this and this also is giving you a P. If your Z is coming below this, which means you can actually stop your study. Whatever happens, this study is unlikely to become positive in future. Very few people do this, stopping for futility. And When you plan your study, it needs to be pre-planned whether you want to stop only for futility, only for efficacy, or both for efficacy and futility, because the formulas differ. And this has implication on sample size. If you add interim analysis, your sample size increases. If you don't have interim analysis, the sample size is easy. If as a clinician, you are going to plan your first study, I would never advise you to put interim analysis. Because when you put interim analysis, which also means you need to have a thorough check over the number of events which are happening. You can't once in a year say, let me see how many events have happened. Every 2-3 months, you need to keep a check over the number of events which are happening. So I hope this answers the planned interim analysis. Atanu, anything you want to add?
Yes, so you nicely present the graphs. One thing I just want to add in the graphs that you are having this, that triangle shape. Within the triangle, if the p-value comes within the triangle, in that means you are okay to pursue the study. Irrespective, yes, within the triangle. If it is a beyond the triangle upper value or lower line value, then you should stop the study and take a call on that. So that's that.
So
In simple way, it
Atanu
is.
is telling you that when you do this analysis at this first day, you can get a value above this. If the value comes above this, you stop
Yes.
for efficacy. If you get a value below this, you still stop the study for futility.
Futility.
If you get the value between this, which means that you proceed and keep recruiting the study and then do the analysis after that. So this is
Yes.
about plan interim analysis. What I'll do is we'll talk about unplanned interim analysis where your so this is unplanned interim analysis. What can happen is when the study goes on, you keep on sending essays to the IEC and the DSMB, and the DSMB may feel that your experimental arm is having a lot of events, and it may do a monitoring, and it depends upon the wisdom of the monitors and the IEC, and they may just ask you to stop the study. Now, when you stop the study for, let's say, for adverse events, how do you interpret the results of the study? We'll see that. The second can happen is when they come for regular monitoring, they can see that observational arm, the patients are having a lot of events because of no treatment. Or like I'll give an example. I'll give a real life example. How many of you have heard about Dr. Dikru's study, N0 study? So that's a shame that only 3 hands are there. That's the only New England Journal publication from India. So the study was in head and neck cancer patients who were T1, T2, N0. At that time, around 15 years back, there was a divide whether they do neck dissection, selective neck dissection, or to keep these patients on observation. So the study answered this specific question: one arm selective neck dissection, one arm observation. And the study was actually monitored by the DSMB of TMH and was told to be stopped because the arm which was on observation, they saw that a lot of recurrence were happening in that arm. Now, what to do if such situation arises? So you had planned something and the DSMB actually tells you, okay, now that this has happened, you stop the study. How to interpret the results at this time? So at that point, we again go back to this graph. You can actually draw this was where the final analysis was supposed to be done, and there's a Z value at the number of events. There are softwares available. GS Design has Oberon Fleming. You can actually, now the number of events because the DSMB has told you to stop the study. So you can see what is the corresponding Z and what that translates into. And if the P is below this, then you actually say that the study is positive or not. The problem is because this is unplanned, this was not taken into consideration when the study was designed and calculated. This is actually a big gray zone area. Some people may say that, okay, it was stopped because it was stopped and it was not supposed to be recruited. even a P of 0.05 or below, if you get, you should take it positive. But the purist will say that the corresponding Z should have been seen, and that should have been converted into the P value. This P is definitely going to be below 0.05, and that P should have been reached for you to stop. So that's why unplanned interim analysis is never a good idea. The third scenario which can happen is, which Dr. Ashe was hinting to you. There's a study going on and it was supposed to go on, but for some reason it is not recruiting. You don't know the reasons, whatever be the reasons, and the PI gets frustrated and he stops the study. Now we'll ask Atanu what to do in that situation. Atanu, study.
Yes.
So it does not get recruited. The PI says, I have done with it, 10, 12 years have already gone. So let's say 700 patient studies, 400 I'm done with the recruitment, I'll do the analysis. How do you interpret the P in that?
Yes. So one thing is that for unplanned study, one thing we always miss, and that after I come to this, how we can pursue this once we are having already spent 10 to 12 years and we are having 400 patients, and what to do. See, for one thing is that for one good thing with this proper plan in interim analysis for prospective randomized controlled trial is that we always keep it in mind that this both the groups between the groups the patients are randomly allocated. What does it mean randomly allocated? Means in terms of the age, gender, disease prognostic status like stage 3 and stage 4, both arms are having equal numbers or percentage of patients, and thereafter we are going to conduct that interim analysis. That need to be fixed always. But what happened in unplanned study, one catch area is that sometimes it might happen that one arm is having very inferior type of patients, mostly 80%, let's say 80% are stage 4 patients and 20% are stage 3, and in another arm it is around 60% stage 4 and 40% stage 3. So it might happen. So in that sense, ideally they are not comparable because these percentage of stage 3s are not equal, or stage 4 are not equally distributed between these two groups. So in that sense, it is always need to keep it in mind while we are going for unplanned study, that percentage of group wise or stage wise, gender wise, age wise, these groups are equally distributed. So that's always a catch area, and sometimes we do miss and get that different results and make an interpretation. So one thing is that. Secondly, as you mentioned that that if you already spent 12 years and you are supposed to get 700 patients and 400 patients are there, what to do? For that, see, sample size determination is not way to pursue because you are already having data. Sample size determination is required while you don't have the data. You are going to make a study or plan a study in future directions, but once you are already having the data, so there is no sense to calculate the sample size again. What is only required is to understand based on your data or event rate, because if you are having 400 patients recruited, obviously out of that 400 patients, many of the event you may accept. So 400, let's say 100 patients were having event. So event could be anything, death, relapse, progression, whatever the event you are defining in your study, that could be there. But let's say out of 400, 100 events are there. And in these 100 events also separated into two arms, like one arm is having 70 events and another arm is having 30 events. So you are always already having the data, having the results of the data. Only you have to do is this calculating the power. So basically, whatever we are doing the sample size calculations, we are in futuristic way, we are going to calculate the sample size. But once we are having the data, we retrospectively, we are going to calculate the sample size, or basically having the sample size, what is the power we are going to determine. So another way for planning a study, sample size calculation, we are calculating sample size by putting this power of it as an ingredient. But when you are having the study data, then based on the sample size, you are calculating the power. So basically it should be calculation of the power of a study.
Okay, so
Dr. Vijay, now if you please, if you add in.
Yeah, I'll simplify further. So there were two issues which he brought on, and I'll explain you there on the graph. One issue was, though it is a randomized study, when you do an unplanned interim analysis, there can be differential prognostic factors between the two arms. And now why does that happen? Because when you do randomization, the randomization is factored in such a way that when you complete the sample size, the prognostic factors for which you are stratified, they will be equally divided. I'll give you an example. Let's say I'm planning a study of lung cancer and I am doing a stratified randomization. Okay, and my block size is 6, and I'll explain what is 6 block size means. And let's say that the things which I am stratifying the patients is for age. I'm saying elderly, non-elderly. Okay, it's a EGFR positive study, so all are EGFR positive, but I'm stratified for 19 versus 21. These are two types of EGFR mutation you can get. I'm also stratifying for ECOG performance status 0, 1 versus 2. We all know that in lung cancer, brain mets has a poor prognosis. So we are also stratified for brain mets present and not present. Now these are the number of stratum. Now how many stratum the patient is going to have? Any idea? So this number of stratifications. Okay, let me show you. Age, elderly, non-elderly. Okay, in elderly, let's focus on the elderly side. It can either be 19 or it can be 21. Okay, in 19, it can be either be PS 01 or 2. In 21, it can be PS 01 or 2. Okay, in 01 or 2, it can be either brain mets yes or no. It can be brain mets yes or no. It can be brain mets yes or no. It can be brain mets yes or no. So in elderly itself, this is 1, 2, 3, 4, 5, 6, 7, 8. Similarly, will be on this side. So there are actually 16 stratums. Now in each stratum, let's say the block size is 6. The block size can be 4, 6, 8. I'm giving a 6. What does that 6 means is, after 6 patients get recruited in that block, so elderly with exon 19 with PS 0 to 1 without brain mets. When 6 patient gets recruited, in both arms there will be 3 and 3. The sequence in this 6 can be A, B, B, B. It can be AB, 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 BA, 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 or any kind of combination which allows you after 6, 3 in each arm and 3 in each arm. Now, when the study is supposed to recruit completely, that is the time when this will get A. Now, understanding in 16, you may have discrepancies. Some patients A would be more, some B would be more, and there is a good chance that when you stopped in between, what he said, that the prognostic factors will be unbalanced between the two arms would arise. So that's one point you understood. The second is, he very nicely touched upon that. Let's say Dr. Ravikant wants to do a study, and that's a study involving use of scalp pulling machines in prostate cancer patients because they are worried about the hair. And he's giving docetaxel to them, and half of them are getting scalp pulling, half are not getting scalp pulling. And after it's a 1,000 patient studies, after 400 patients are not ready to get recruited because everyone is saying that okay, the hairs are been preserved, and no one wants to get randomized to the arm without scalp pulling. Unlikely a situation to come in Muzaffarpur, but let's assume that this happens. Now, the thing is, now he can't do anything. He just stops the study after 400 patients. He can still use the P, which was planned of 0.05. But what he loses is the power. What he loses is the ability to see whether there are the chances of false negative in this situation increases dramatically. Okay, so the chance of false negative results in there. So if you have a study which has been stopped for logistics issues and it has significant results, it still is okay if the prognostic factors are balanced between both arms, because that is one thing which is likely to come. If you have a study which is stopped in between, and you see that sometimes they say it was going towards statistical significance. There is a likelihood that there might be a false negative results which has come because of less recruitment of patients. I hope, Asha, that answers your question. Okay, so we'll move on with the next question.
To ask this next question in this context only, that can you change the sample size midway between the study? Because your old sample size calculation was based on some XYZ data in the literature, but now you have a new response rate as per the new studies. So can you revise your sample size midway between the studies?
So, Atanu, I'll reframe the question to you. And this actually has come from Dr. Venkat from Adyar. I know the question from where it has arises. A sample size was done based on Western data. Okay. And the study has already started. But in between, a retrospective analysis was done at the center. And they now know that the standard arm sample size. So they had assumed 5-year survival of 30% in the standard arm, but the retrospective analysis actually suggests that the 5-year survival is only 10%. So what to do when you come across this kind of things? Can you revise the sample size when the study is ongoing? That's the question.
Yes. So yeah, it could be happen, and it can be answered. It can put us in two directions. One thing is that based on the updated informations, are we going to change our outcome of the study or not, or primary objective of the study or not? It might happen that since you calculated the sample size or planned the study based on the Western data, now you are having your own center data, and based on the own center data, you are going to recalculate the sample size. In addition to that, you also might fine tune your study objective or primary objective, I would say. If you are shifting your primary objective from the earlier study objective, then it is better to consider it as a new study and put it as a new study proposal and calculate the sample size as a fresh and perform the study. But in that case, if your study objective is remain same, you are just using the updated informations to calculate the sample size. And as you mentioned that it is your own study center data. So we always prefer to have the study samples data, because the informations that we need to calculate the sample size as nearer as possible from our real life scenario. So as you mentioned that your study data is from your center itself, so it is always preferred to consider your own center data and recalculate the sample size based on the updated informations, and it's very much okay unless and until you change your study objective or study design. And for that purpose, you might require to approach to IEC to resubmit your modified proposal or amendment proposal with recalculated sample size. But I think that is okay to pursue with that.
Okay, so I hope that answers the question. Everyone understood that? So the thing is very clear. If your endpoint was 5-year overall survival, you want to keep the same endpoint, but want to revise your calculation, you can do that. You need to approach your IC with the game. But if you're going to change your endpoint, let's say the OS is going to become DFS, then it's better to submit a separate proposal. And it's very important that you have a look at your own data. And I'll just tell us a experience from our side, and my neuro team is not here. We did a study of repurposing of mebendazole in glioblastoma. We were looking at whether addition of mebendazole to CCNU leads to an improvement in outcomes or not. The success rate of the study was that at 9 months, the overall survival should have been above 55%. This was taken from a European study called BELLO, which was done by Juan Martin Vanderbilt, and this was used. When we analyzed the data, after obviously we did the phase 1 for mebendazole and then we went ahead and did the phase 2. We failed miserably to achieve this. The 9-month overall survival in the CCNU plus mebendazole arm came out to be 47%. And when the study was actually ongoing, we used to use CCNU in daily practice. And when the study was actually ongoing, it was a feeling among the investigators that the mebendazole addition was working well. But when we analyzed the data, it didn't seem so. And hence we actually went to see why that we got these results. What we saw was the BELOP data in relapse glioblastoma recruited only PS0 and 1 patients. Now, those of you who look at neuro will know that in GBM, PS2 and 3 are actually the majority of the patients. Very few patients are PS0 and 1. But that's what the BELOP study had done. When we had actually written the protocol, we had allowed the protocol was by the name of reverse swing. We had allowed PS0 to 3. And nearly 35 or 40% of our patients were PS2 to 3, with 3 accounting for around 20% of the patients. Now, whoever knows a bit of oncology would also know that if you have this group of patients and you are comparing the outcomes with this is like not apple and oranges. This is actually pea and a football. And if you restricted the analysis in our study to 0 to 1, it actually crossed this margin. So I always feel that that was some amount of inexperience from my side when this study was planned in 2015 and 16, where we should have looked upon our own data at what is our distribution. Because of this, we had to conclude in the paper, because this was pre-specified that mebendazole does not work with CCNU in the whole cohort. However, Lancet actually allowed us to put a line that it needs to be explored further in PS0 and 1. But I'm very sure that if you would have, because when our data, Dr. Nandini is actually downstairs, when we saw our own data, when there were similar PS2 and 3, our 6 month, this is 9 month, our 6-month OS was only 30%. And this was 600 patient data. So if we would have this value, this definitely would have come as a positive study. So it's important, first of all, that when you do the studies, it try to get the data from your setup, either your institute or institutes which have similar setups. Second is, it's important that if you get like Dr. Venkat got here, in between you are seeing that your assumption is something different, it's better you change the sample size if it requires to do so. Any questions? And it's okay, you can ask any questions you want. Yeah, mic le lo.
Are all unplanned interim analysis underpowered, or they have not reached?
By definition, yes. Because when you say type 1 error this, type 2 error this, and you get a sample size is this, if you stop before that, yes, the power will be less. Okay, so that is yes. So you can't compensate. So you actually see, you can't compensate anyway under power. You can continue with the study if you do an unplanned interim analysis. If your IC asks to have a look at the data, what you lose is you now need, so when you do, let's say there's no interim analysis. Your P at the end is 0.05. You do one planned interim analysis, not unplanned, you allocate some P here. So your final P is actually less than 0.05. And that would be depending on the complex calculations the statistician would meet. Let's say that it is 0.04. You did an unplanned interim analysis, 0.04, and the final P, when you did actually the analysis came as 0.045. By definition, the study is negative.
So
Yeah.
If the power is it has not reached, then why do the unplanned interim analysis?
So unplanned interim analysis is never planned. Unplanned happens because something happens. So for example, there were the three situations which can happen is one, you report adverse events to the IEC, and IEC in its wisdom and the DSMB in its wisdom feels that too many adverse events are happening. So let's have a look at the data on the basis for safety. The IEC does a monitoring of your study, which regularly, 1 yearly, 2 yearly, they keep doing. They feel that as in N0, in the other arm, standard arm, too many events are happening. So they are again doing it for patient safety. Third is like a situation like say Manu is trying to do a study in Kerala. At that time, 5 centers say, okay, we will collaborate. And at the end, he is the only person who is doing the study, which is a very common situation in India. And he can only recruit 400 patients. The sample size was 1,000 patients. He said that it is impossible for me to continue. Funds are not there. He stops at 400. So no one wants to do an unplanned. Unplanned actually happens because of some of the other things which happen. And quite a few studies have unplanned analysis.
One thing is that very important to clear is that this intention to conduct any interim analysis is basically protect the patients. So something miserably going wrong, not going wrong to the patient, that is need to be only reason to conduct any interim analysis. But if you talk about we want to conduct the interim analysis to publish the data earlier, no, that is not going to work, because always the study strengthening, I would not say only the power, I would use the study capacity is not good enough to publish it or complete it unless and until you complete the study with this entire sample size. So very important point is that we should conduct interim analysis only to understand something wrong is happening to the patients or not, or protect the patient. That's all, not for the study publication purpose.
There's a question. Pritesh, take the mic.
How much importance should we give to unplanned, or how much importance should we give to a subset analysis which was not predefined and done after the study? So a lot of studies which are negative in the which result negative, but they later on say that we did a subset analysis in this group and which showed that there was significance. So how do we take that?
So for all practical purpose, not pre-planned subgroup analysis is hypothesis generating, which means, let me tell you that I did a study of in adjuvant, I'm giving metronomic versus not metronomic in T3, T4 patients of laryngeal cancers who have undergone CTRT. I do the analysis, the study comes negative. I see that in patients who have extranodal extension, there is hope that addition of metronomic might improve the outputs, because that's a worse subgroup population. This is hypothesis generating. This hypothesis needs to be tested in another study. I cannot label on the basis of this study that this is, but this is, sometimes what happens is there are pre-specified subgroup analysis which are written in the study protocol. So it's always important that when you read studies which define treatment, you do not only Anbarsan, have coffee and come in. Go have coffee and come. Yeah. You do not only do read the paper, but you also read the study protocol, because it's the study protocol which is the most important document. The study protocol actually gives an idea of what the study team was thinking when they were planning the study. And in that, if they have put a predefined analysis, this we are going to study. So the two things needs to be there. You need to predefine, and you also need to define the direction, which means that we think that in this would be improved to a larger extent or something of that sort. So in those things, you can take those predefined analysis, subgroup analysis, they predefined the protocol and even the direction was maintained, because if they were able to tell the direction way back 4-5 years, which means there was a biological rationale for doing that predefined analysis. So for example, when the IPAS study came first, IPAS is the study by Tony Mock, which established Jeftinib way back in, it's a New England Journal in 2007 or 8. And he didn't take EGFR mutated patient. He selected patient who had clinical features who are likely to be EGFR mutated, a female, a non-smoker, and such kind of patients were selected. There was a predefined, planned subgroup analysis of EGFR mutation versus no mutation, which was defined. And that we all know started using Jeftinib after IPAS scheme, because so you need to have this predefined analysis, subgroup analysis, which is then you need to give the direction also. Now, the question can come, when you do such subgroup analysis, how do you know that there is an interaction between the study arm and what you're looking? So let's take the example of EGFR mutated here. Atanu, you want to add anything?
Yeah, so basically, in continuation to your remarks, so see, study results can be separated as two kind way. One thing is the confirmatory study, and another thing is the exploratory study. So confirmatory study is basically based on your primary objective of your study, and that's why you calculate the sample size and defining the protocol, and based on that you are making the comparison, getting the results. But in addition to that, with this hypothesis given study or confirmatory study, during the data analysis you can come up with different subsites or subgroups and can get the results. One subgroups are having different better results as compared to other subgroups. So you can eventually you can invent, okay, this is EGFR positive, this is male, and thereafter age below 30 years. So these are going to be having very effective, or outcome is going to be very exciting. But thing is that these are all exploratory study. They are not adequate in terms of the sample size calculation, in terms of the power. They are going to give you some light or path to go forward. Next level, if you want, you can conduct some study dedicated to with these subgroups. There is having, let's say, EGFR positive, male, 30 years below, and any other way of you want to conduct. But don't jump to a conclusion by looking on the exploratory study or exploratory subgroup analysis results, and don't make a conclusion on that. Sometimes there is people having tendency to put more light on the subgroup analysis because their main primary outcome is not being done, or results are not coming as expected. So they gives much trace on the subgroups part and give more presentation on that, but never buy these kind of product, because these are not that real study driven analysis. These are all exploratory study analysis.
So are the pre-specified subgroup analysis can be the same as that of a stratified analysis? For example, age. We haven't defined pre-specified subgroup analysis based on the age factor, but we have stratified age more than 65 versus less than 65. So are they the same? Can we say that these are pre-specified subgroup analysis, or they are different?
They're different, Anil. You need to specify which before which you would be looking at. Normally what we do is, whenever we do the forest plot, we normally tend to give the forest plot for the things for which we are stratified, but it need to be pre-specify that you will do for this. I'll give you one example what you would look in when this such kind of subgroup analysis. What we do is called as interaction testing. So you are seeing whether the arm has an interaction with this factor. And let's take Jeftinib as the arm, and EGFR mutation positive and negative, what was seen by the famous Tony Mock New England Journal publication. And you can have what you're looking is whether there is a difference in the way the group was divided on this biomarker, whether they behave differently. The difference in the behavior can be two ways. Either the benefit was more in one group versus the other. Both benefited, but one benefited more than the other. This is actually for those who, this is a snapshot of a forest plot. What I'm highlighting is a hazard ratio. This is the median hazard ratio. This is the 95% confidence interval. This is unity 1. So anything before here is better for the experimental arm where we had written Jeftinib here. Anything on this side is better for the chemotherapy, what I've written chemotherapy. Clear with this? So what has been shown in this graph is there is one subgroup X and one subgroup Y. This has a better hazard ratio. 0 is here. Then this. So there is benefit in both because this lower limit of 95 confidence interval is better than A. So there's benefit in more, but it seems visually that X has benefited more than Y. And you would see these comments coming a lot of time, Pritesh, that in this there was more benefit. Let's see how do you actually statistically say whether there is more benefit or not. In this, they would say, okay, there is mutation positive. There is not much benefit in mutation negative with Jeftinib. How do you actually conclude that this is there or not there? You need to look at the interaction testing p-value. If the interaction testing p-value is below 0.05, which means this difference actually exists. If it is not, then this difference actually doesn't exist. Okay. Now, sometimes one more thing which you'll see is, I'll just put it here, that the graph is like this, but this has crossed. Okay. And then people will say that the unity has been crossed. Now understand that this is the confidence interval. The confidence interval is a function of two things. It's a function of median, but is also a function of the sample size. Let's, for example, I do a study in head and neck cancer, and most of the head and neck cancers are male. Females are a bit less. In most of our studies, oral cavity, you'll see 80-85% are males and females are less. And let me try to draw another forest to explain this point, which is an important point as clinicians to remember. Male, female. Let me say that this hazard ratio came here and female it slightly came here. This can also happen if, let's say, you are looking at brain mets yes versus no. Brain mets yes has poor prognostic factor. So the increment which you get with the intervention arm may not be that high. Brain mets no has a good prognostic factor. The increment which may get may be high also. So this is also dependent upon a function of prognosis. So interaction test also looks for that. And let's say that 85% of the patients are males. So obviously the confidence intervals are going to be very tight, which means they should be narrow. You're getting me? Okay. Now, let's say the study was of 1,000 patients. So 850 were males, 150 were females. Obviously the confidence interval for 150 is going to be broad. So you need to also look at this. And that's why that interaction testing value remains important. Now, why is the confidence interval a function of sample size? Anyone? So whenever you remove confidence intervals, you actually look at standard errors. Standard error is inversely proportional to the sample size. So the higher the sample size, the standard error is going to be less. Obviously, the confidence interval is going to be small. So just remember this thing. You will get shorter confidence intervals if the sample size is high. Okay? Are we clear? And so, yeah, just a second. And hence, for such things, you always look at the p-value. Yeah, you can wait.
So, but interaction testing p less than 0.5 is also only hypothesis generating, no?
So What you are saying is correct. If it was a post hoc analysis, yes, it is also hypothesis generating.
But but that sample size is never powered to answer that question, no, sir?
Yes,
So
that's
does
correct.
interaction testing help us in that process?
No. So I'll tell you what interaction testing helps me. Let me take this example again. Let's say I was Tony Mock when I planned the study. I have not specified this pre-specified analysis. So this is now a post analysis. Now I want to see whether Jeftinib actually benefited more in EGFR mutation positive. And my thing is, okay, if it is benefiting, I'll do another 600 patient randomized study of EGFR mutated. So whether to go ahead with that study or not, whether this hypothesis actually exists or not, I will do hypothesis testing and I'll say, okay, I need to go with this. But Tony Mock was smart. This was a predefined, pre-specified analysis, and he had also given the direction that it would be better than the EGFR negative because biologically it seems so. And he did this. Now, depending because of this interaction testing, it actually got it actually got started to be used. So see, we must understand that as clinicians now, we have never been pure with statistics. Many of the subgroup analysis we have actually incorporated in practice knowingly or unknowingly. For example, extranodal extension and margin A. If you look at the RTOG study and the URTG study, one study had only these factors, the other had a lot of factors. When the combined analysis was done, we only took these two factors because their P was had a major benefit. So we always have been using such things. Second is a good example. Those people who have good thoracic units will tell you that if lobectomy can be done, it's better than CTRT. The SPUTE trial, which actually gave these results, was actually this was a subgroup analysis. Overall, there was no difference in outcomes, whether after neoadjuvant chemotherapy you do CTRT or you did surgery. This was a subgroup analysis. So there is a sense of what I would say is one thing you look at statistics, but one thing is pragmatic use of the data also. Yeah, like for example, we'll always say that you need a non-inferiority trial to change the standard of care. We all use gemcitabine, cisplatin in urinary bladder in metastatic. Go and read the study in which it was compared with MVAC, not DDM. In the MVAC, it's a palliative setting study, came way back. It was actually to show that gemcitabine cisplatin would be superior than MVAC. It didn't prove superiority. Statistically speaking, was a negative study. We shouldn't have been using gemcitabine cisplatin. But the side effects with gemcis were so less than the MVAC, and the data showed that the curves were on top of it, that we just accepted that gemcitabine cisplatin could replace MVAC. So what you're saying is correct. Many times clinicians do take these judgmental calls, which yes, that we need to know when we take this judgmental calls, what are the pros and cons of taking those judgmental calls.
Just one more doubt, sir. What we mean by pre-specified analysis, does that have an implication of increase in sample size?
So I'll tell you, when we say pre-specified analysis means, when you wrote the study protocol, you would have defined that I'm going to do this analysis. And I'll tell you why that is done. Let's say I do analysis of all patients in the study and say I'll compare all patients whose name starts with A versus non-A. Then I'll do a comparison of B, non-B. I can have 26 analysis. A to Z is there. Na? So A, non-A, B, non-B. When you do roughly 20 tests, one will come positive, because that's the false positive rate you will have. That's why you need to pre-specify that I'm going to look at this. The reason why I'm going to look at this is the biological rationale. And with newer targeted therapies coming up, with newer PDL1 studies coming up, you will be seeing this more and more. Now, I won't add more complexity. There is something also called hierarchical analysis, where you would start with one. If that is positive, you will go to next. If that is positive, you will go to next. And good example is Keynote 048, which is a study of chemo plus cetuximab versus chemo plus pembrolizumab, which first tested in PDL1, it's a CPS actually, but let's take PDL1 20% or more positive, then tested in PDL1 1% or more positive, then all patients. So different, there were actually 12 and a pre-specified hypothesis which got tested in this kind of sequence. We don't fall. That is actually higher level of statistics, and that would take a lot amount of explanation also. But the thing is, if it is pre-specified, there is a thought process behind that, and most of the statisticians and clinicians would agree with that. We'll go to the next question, Ashay. What's the time?
Is it possible to do a 3-arm clinical trial? There is 1 standard arm versus 2 intervention arms, superiority design. Power to show superiority of interventions over standard arm and 1 intervention arm over another.
Yes.
What the question? 3-arm study?
Yes. So, yeah. So before that, I would like to say something about this conventional 2 arms and in terms of the 2-arm studies with, in terms of the overall survival or progression-free survival comparison. But anyway, as you already said, so let us give some picture about that. What happened when you conventional make the comparison for these ways or PS-wise comparison. So yes, we consider that as a reference arm, as a control group or existing therapy as a reference group, and with respect to that, another groups we make the comparison. So comparison can be 2-way, can be performed in terms of the, I'm now coming in the area of this survival analysis or the oncological trial, where outcome can be defined in 2-way. One thing is that in terms of the percentage, like event rate, like death rate, like progression rate after certain time point. This is the one way we always capture the outcome of interest, and based on that we calculate the sample size. Second way is to consider the median duration of survival or median duration of progression-free survival, median duration of relapse-free survival. So these are the 2-way. So irrespective of the way it is going, means percentage or the event rate wise comparison or the duration of median survival comparison, both the way we consider the existing arm as a reference arm, and with respect to the reference arm we try to find out what happened or what is or anticipated outcome for the experimental arm. So this is the way. So it is basically one hypothesis and one with this reference group with respect to the experimental group we make that thing. That's the way the 2-arm comparison makes. Now for these 2 arm, we can make one arm as existing or the reference or control arm, another is the experimental arm. But if you truly think that one arm and the existing arm or reference arm could be another new treatment arm, that is also fine. So both arm can be considered as experimental arm or running experimental arm, I would say the word. Both arm can be considered as the running experimental arm, and we can make the comparison and calculate the sample size, conduct the study. But while you are talking about 3 arm, so in that sense, we have to consider these 2 arms, means one arm as a reference category, and with respect to that one arm, first, second arm and third arm, both will be considered the comparison. So now it's up to you which one out of these 3 arms, which one can be considered as a representative of the reference arm. Representative of the reference arm means that should be conventional arm or some extent the very minimal effective arm, or let's say very usual arm, therapeutic way to perform the treatment. If you're okay with the consider that one, I would say some so-called kind of reference arm, then obviously with respect to that arm, 2 other arm can be compared as, and we can very easily perform the study with the 3-arm calculation study design as well. Yeah, that is possible. In terms of the technical methodological issues, I think we need to have some mathematical algorithm over there to be kept in mind while you are performing the sample size and study design. But it is possible to perform with that. Yeah.
Okay. So the Atanu, can you
Yeah.
show one sample size calculation? One of my observers is getting very anxious that there's no sample size calculation actually shown. Can you
Okay.
share and show one?
Okay. So just I was thinking to show some kind of thing. So, calculating sample size.
Give me 5 minutes. I'll explain them P0, P1 so that they know
Okay.
what it is. So whenever you actually go for a sample size calculation, you need to know, see, why are you doing that? You are doing it so that you improve the outcome. So obviously there will be something called P0. In statistics, P0 means what is just baseline outcomes. Let's say, sorry, I do only neuro, head and neck and lung. So my examples will be only from this 3 groups. And let's say that I'm looking at oral cancers, locally advanced oral cancers, surgery, radiation, CTRT. 5-year outcomes is only about 30%. 30% 5-year OS. Now, I'm impressed with the data of neoadjuvant immunotherapy which has come in lung cancer, and the phase 2 data of Dr. Ravi Upaluri, which was presented in last year's ASCO, in which it did show that 2 doses of pembrolizumab given before surgery actually led to very good path CRs to the tune of 47%. And we all know that higher the path CR, higher the chances of survival. So I think I'm planning a study in which 2 doses of pembrolizumab given would lead to improvement in outcomes. The question comes, how much improvement in outcomes you want to see? So what you can do is you can actually go to the phase 2 data and see how much improvement it gave, and you can put that figure. Let's say that it improved by 10%, so I can use 40%. Sometimes, let's say that Manu said, okay, sir, we might do a study of 2 cycles of pembrolizumab and then surgery. But most of my patients can't afford full dose pembrolizumab. So he says that you did a study of low dose nivolumab and palliative. Why don't you do a study of low dose pembrolizumab in neoadjuvant? Now, I don't have much data about low dose pembrolizumab in neoadjuvant setting. So how do I select how much improvement in outcome needs to be taken? What I do in such situation is I go to a scale called ESMO, magnitude of clinical benefit scale. These are recommendations which are given by ESMO, which tells you that if you want to use an intervention, and it definitely would be recommended, they have categorized as type A recommendation, type B recommendation, type C recommendation. In palliative as 1, 2, 3, 4, and 5. Type A and B is for curative settings. For outcomes, which is similar to 5-year OS of this, how much improvement in hazard ratio needs to be there for that recommendation to be used in clinical practice? So I will actually take that shortcut and say that the arm which I'm going to use should give me at least the type B recommendation. There's no point in doing a study and getting a type C or type B recommendation, which as such I'm not going to use. So let me go plan it for type B recommendation only. And I see that hazard ratio and I get it calculated from Atanu for that. Type 1, as I told you, is false positive. So conventionally people will keep it at 5%, or what you would say at 0.05 would do the P. Type 2, you normally keep at 80 or 90. How do you choose 80 or 90? It actually depends upon how much money you have in your pocket and how much your funders are going to give you money. And it's as simple as that. It comes down to that. How much a 10% increase in the power will means 25% increase in sample size. So if you're someone like Anil who has IAEA funding behind him, you can go for 90% power. If you're Vijay Patil, for whom the funding has to come from ICMR, DBT, or backing around, he will go with 80% power. You also need to specify to Atanu how much long is going to be your recruitment period, how much long is going to be your follow-up period, and what are the chances of your loss to follow-up. The chances of loss to follow-up will come from your previous experience or during the study. If you are a newbie, then it's better to look from your seniors' experience, 10% loss to follow, 5% or 20%. Obviously, it's simple. More the loss to follow up, more the sample size would increase. And a recruitment period and follow-up period, I'll come to one. Let Atanu show an example, and I'll show you how your recruitment period and follow-up period can also have a implication on sample size. Atanu, you show one calculation, man.
Yes, so I'm going. I hope you can see my slide.
Yes.
Yeah. So let's say this is one example I brought from that library called GS Design. It's applicable in R. So that Dr. Vijay already mentioned that group sequential study, and these packages GS Design is basically for group sequential design study.
Atanu, give me a minute. So what you're seeing here is actually a R portal. R has libraries and packages on this side. That is the command, and you'll get the output here. Okay, so you just enjoy it, how it works. This is the best form of sample size which you can get on our portal, and GS Design is one of the best softwares which is available for doing a sample size calculation. Atanu, please continue.
Yes. So just you have to install that package, or you can freely install this Art Studio, Art software. And nowadays YouTube, you can go and check how to install software and art software and packages. So I'm not going into details on that. So whatever the results are going to come, it is going to come here in below window here. So let's see. This is a syntax, only one line syntax you need to run. I'll explain what does it mean, each syntax meaning, and I'll run as well, so to get an answer. So this is n survival, small n, then capital S, then survival. So look, this R is case sensitive. So capital S means you have to always put capital S to put the n survival. So this is a function that these functions calculate this sample size, calculate the sample size. And for that we already discussed some, what is the inputs we need. So few of these things we already discussed, and few of them we will see here, and we will explain. So these are the inputs we need to have to calculate the sample size, particularly while we are talking about in oncological trial, where our outcome is progression or death, look on the death rate or progression rate or relapse-free rate. So since we talk about the progression rate or relapse-free rate, so always we consider the terminology called hazard ratio and hazard rate basically. So hazard is basically the death rate we are considering. So in mathematical books or statistical methodological books, people do considers the mathematically the hazard rate as lambda. So here you will see two values of lambda is given. One is called lambda 1. So not values, this is a basically name. So this is lambda 1 and this one is lambda 2. This is basically talk about this one group, treatment group hazard rate, and it is anticipated that this treatment group, or let's say this existing group or the reference group or the control group, whatever you say, for that the anticipated hazard rate is 0.2, means 20% will die after certain time point or relapse after certain time point. So that is 20% is converted as 0.2, and that is been given as lambda 1. Similarly, another group that you are expecting that it is a better group, or it is basically the experimental group. So in that group, you define the hazard rate as lambda 2, or call the hazard rate for that group as lambda 2. And for that, you define that, or anticipated value for hazard rate is 0.1, that is mean 10%. But for the both group, existing group, that is for lambda 1, and experimental group, that is lambda 2, both groups, what you are expecting that after certain time point, what is the hazard rate is going to happen. So in that sense, both group has to pass some certain equal number of study interval. So define that study interval. I will come this eta value later, but now so this study interval should be by and large in sometimes it could be in months, it could be in years, or it could be in decades. But for the timing, let's say it is, we consider it as a unit, could be anything, but let's say it's a study duration, we are going to consider as total duration of the studies as a 2 years. So this 2 years TA stand for the 2-year study durations. Anyway, it could be in month as well, no problem. You can consider as a 2 months, no problem. But in addition to that, while in survival analysis or oncological research, what happened that one day or single day, you are not going to get the patients. So you have to conduct the study, and enter years, you are going to get 1 and 2 patients every day, or 1 and 2 patients in every week. So your recruitment is not going to complete in a 1 day or 1 month or even 1 year. So, but while you are talking about the sample size calculations or study design, then you have to have some consideration that what should be your recruitment period. Because if you think about a study should be 5 years, it does not mean that you continue the study or continue the recruitment for 5 years. It's not possible, because the patients joined your study or recruited at the end of 5 years. You have to give that patient also good amount of follow-up period. Otherwise, you are not going to get any, you can't expect any event for those patients. Okay. So if you're thinking your study is for 5 years, you have to wind up your recruitment period, let's say within 2 years or within 2.5 years. It's obviously depend on study to study, duration of the median survival of the study and recruitment period, study site you are talking, prostate cancer, breast cancer could be varying differently from lung cancer and head and neck cancer. But that's a different story. But you have to have some rule about what time you are going to complete your recruitment. Once that the last recruitment is done, after that you have to give certain amount of period to complete the follow-up, because you have to give the last recruited patients to a good amount of time to be followed up. So that's why your inter duration of the study need to be specified into inter duration as by TAs and recruitment period by TR. So these are the another points. So once the questions came that what are the important material need to be considered by calculating the sample size, as I mentioned, alpha and power, but it is not the only one thing. There are other parts, and these are all aligned with your study design, because we are talking about the oncological study design, prospective randomized controlled trial. So in that sense, these TAs and TR, all these notations comes together in addition to that lambda 1 and lambda 2, because we never get that opportunity to work with lambda 1 and lambda 2 or hazard rate if you talk about some observational study like incidence type of study. So it's only comes when you are talking about the survival or the oncological study. So lambda 1, lambda 2, it's done. Study duration also split into 2 parts as a TAs and TR. Now, sometimes we might happen that what you are anticipated loss to follow up, because you know that all patients are not going to be followed properly, because many of them are going to be lost during your study. So even if you give them good amount of time to be followed up for 5 years or 2 years even, still many of them are going to be lost. So what is your anticipated loss to follow up? Is it a 10%, 20%, 30%, more than that? So that percentage figure you can calculate based on your, based on your experience, based on your senior colleagues' experience, or some retrospective auditing the data, earlier data from your center. So that part need to be captured by eta value. That is, it could be, again, it can be maximum 100%. So nobody is going to be lost to 100%. So commonly we consider as a 10 to 20% value over here. This part now is this ingredient is called, we are talking about that side. It is a two-sided or one-sided. So if you are talking about the side, that's mean that you are expecting that lambda 2, that is the experimental arm, is always going to be the better hazard rate as compared to the existing arm. If you thinking that no, it might happen that experimental arm could be poor performer than existing arm, in that sense, it is allowing to consider the side as by considering by in place of 1, you can consider side as 2. So basically, if you say in other words, if you are not very much confident that your study experimental is strong or not strong, it could be poor performer or good performer, both. If you are in that dilemma, so in that sense, it is better to consider as a side is equal to 2. But if you are very much confident that anyway your experimental is not going to be poorer than your existing arm, it is definitely going to be better or at least similar performer with your existing arm. In that sense, you can consider sided as 1 rather than that. So that's all. Final that we mentioned about that alpha value, and if you consider that alpha as 0.025, 0.05, you can take point in place of 0.02, you can consider 0.1 as well. So as we keep on increasing your alpha value, your sample size is going to be lesser and lesser. That experiment we will do. So only this part is required. So only two line you have to need to write: library, GS design, and after that SS1, N survival, and this. And just to run these 2 lines, just put your crusher here, click on run, and line that, and thereafter you just call SS1 that we define it as. So see here, we are going to get so many results, so many things here. First of all, it's giving us in which, based on the literature, it's calculated the sample size. So based on the 1986 paper of Lachin and Flokes, that's the study based on the sample size calculation, they gave the derivation. Based on that, it is being done. Now, this is basically giving us study accrual period, study duration period, and study accrual period. So remember, so it's never say about it's a, what is the unit of this. It could be 2 months, it could be 2 years, but you have to be the unit should be unique enough for your study. So if you talk about two decades, no problem, pursue with the 2 decades. So corresponding to 2 decades, half decades, that's mean 5 years should be your accrual period. If you talk about the 2 years, corresponding to that, 6 months would be your accrual period. It says about the uniform accrual period. So are you going to take all patients within a 1 month, or 80 patients within 1 month and rest 20 patients in rest 5 months, or for entire 6 months you are going to get equal number of patients? Commonly, it is common phenomena that we always consider the equal amount of patients being recruited every month or every weeks. So that's why it is better to consider the uniform recruitment, unless and until some real phenomena like COVID kind of things happen. So we never consider as unequal, uniform distribution. So basically we consider the equal uniform accrual period. Now, as we mentioned that lambda 1 and lambda 2, these are basically converted into controls arms median durations and experimental arm median durations. And as we mentioned that what should be the censoring part over there, that is the how many are going to be lost to follow up from your study, even if you give them good number of study follow-up, that going to calculate the censoring median durations or median time. So basically eta is used as we mentioned, as here in eta is 0.1, that's been converted into 6.9. So all this being done, and by default power is going to be considered here as a 90%. Type 1 is basically, as we mentioned, that alpha is equal to 0.025. This been considered to calculate the type 1 as 2.5%. Allocations, because are you going to get the equal number, randomly equal number of people that have been divided into experimental or existing arm? So that allocation ratio is going to be 1:1 ratio. Eventually we can modify here if you want to have the 1:2 ratio or 1:1.2 ratio, that can be changed here. And finally we are going to get the required sample size as 430. And not only that, this product also gives us the required number of event you need to get, that is 91. So what does it mean? Either if you are having 91 event before recruiting 430 patients, you can wind up your study. You can say, look, my study sample size was calculated with both the value with 430 individuals with 2 years study duration and half years accrual period, as well as 91 event. So if you it might happen that you are not in a position to continue to more recruitment because your study objective has changed, new drugs or new therapy regime has been introduced in the market, but still you want to continue your study rather than taking new patient, recruiting new patient in your study. In that sense, if you are having more than 91 patient at least recruited, so you can expect, or at least let's say 150 patients are recruited. So if you wait, because you don't have other way choice, because you are not in a position to recruit more patients for this study because market has changed. So in that sense, you can wait for, rather than 2 to 3 years, you can wait for more years. And let's see what happened. Those who were recruited earlier, how many were having raised with the event. If the events comes more than 91, you are very much okay to compile your study or round up your study, even you are not calculate or get your 430 patient sample means being collected. So this is the this is the way to get the sample size calculations with all remarks. Just I will change one point from here, and then after that I will sorry, I will take some question. So see, just example, just we say as alpha is 0.025. Now if I change from 0.25 to 0.05, that means I am increasing my type 1 error. Okay, so look here, type 1 error was 2.5%. So if I make that alpha is 0.05, my type 1 error is going to be more from 2.5 to 5%. My power is remains same, eta value remains same, lambda value remains same, lambda 1, lambda 2 value remains same, TS, TR, every values remain same. What only change is in terms of the sample size. Initially we were having 430, and now we come down to 352, only just shifting from 0.025 to 0.05. And simultaneously our event number also changed from 91 to 74. So this is the way. Now Dr. Vijay already mentioned that you have to look about the feasibility of a study. Sometimes what we do, what we understand that even if we say that 430 patients need to be recruited or 91 patients even need to be done, but in small center or very remote area, it's not always possible to get these number of patients, or it's need to having huge time investment. So in that sense, to try to make it much more feasible, we try to consider that reduce the power or reduce the alpha value from 0.05 to, let's say, even more. So now from only just from 0.05, I change it to 0.1. See, drastically now my sample size has been reduced from 352 to 272. It will keep on decline once you keep on increasing your type 1 error value. Simultaneously, you can change your type 2 value as well. I think beta 1 will work. and beta, if you mention 0.8, I think it will show you beta value. Let's see, now beta is coming from earlier it was 90%. Now beta value is came only 20%. So see, now sample size has been reduced only 8, but one thing is that nobody is going to, beta should be not 8, beta should be 0.2. So now from 90% it came down to 80% power value, that is based on the beta value. Power value came down to from 90 to 80%. Alpha value remained 10%. Still from 180 it came down to 186, where we are having where power was 90%, that was 272 with 57. So these are the all changes we can do. Not only the alpha and beta value, the assumption with lambda 1 and lambda 2 value we can make an attempt. As the difference between lambda 2 and lambda 1 is more, you are going to get less sample size. The difference between lambda 2 and lambda 1 is less, you are going to get the more sample size. Just one another example, I will not change alpha value and beta value, because ideally if I remain this earlier with this alpha 0.1 and beta as 0.1, then I'm supposed to get 272 and 57 even. But rather than 0.2 as lambda 1, let me put as 0.25 for lambda 1. Just I'm put 5 place more difference between. So now here the difference between lambda 1 and lambda 2 is 0.1, but here the difference is becoming 0.15. These things are unchanged. Let's see what happened. See, since I increase the distance between lambda 1 and lambda 2, sample size again reduced from 272 to 142. Eventually, if I decline that distance between them, 0.25 to 0.15, let's see what happened. So see, it increased rapidly from 142 to 902. Sample size become more now. So this is the way. This is a wonderful function, I would say, to calculate the sample size calculation as far as this oncological randomized control trial is concerned. So there are n number of design, n number of way to calculate the sample size, but every sample size calculations always rely on this alpha and beta value. This is the most important parameters. And in terms of the survival or oncological trial, lambda 1 and lambda 2 is another part. And study durations is third component that always need to be considered. And finally, the loss to follow up, the censoring part, that need to be kept in mind. So this is the way we do calculate the sample size and make the interpretation on that.
So any doubts up till now? So just for example, P0 was lambda 1, P1 was that lambda 2, plus alpha and beta were type 1 and type 2. Recruitment period and study duration he has shown you. Atanu, can you do one more? So I told you we'll talk about recruitment and follow once he shows you. So up till now you understood more the difference between the two arms, smaller the sample size, smaller difference, smaller. If you increase your alpha, increase means 5% goes to 2.5, again the sample size will increase. If you increase your power, that also will increase your sample size. Now let's say that I give the sample size to Manu Prasad where 10% has to be made to 15% with this, and it says 900 patient is not possible. Have a look at the number of events. It is 163. Atanu, can you change that study duration to 10 years and accrual duration to 8 years and just show what happens? Okay, now see that he has changed the study duration to 10 and the accrual duration to 5 years. Can you see that? Look at the number of events. It is nearly similar, 163, 161. But the sample size has gone drastically from 902 to 364. So remember, sample size actually is a connotation for number of events. You are not looking at the sample size. So you're actually looking at the number of events. And for number of events, means if you give the data time to get mature, you will get higher number of events. If you want the result faster, you require a large sample size. So we always tend to fluctuate among these two. We never try to fluctuate among these two. And when you can actually, and practically, it is not going to be possible for Manu to recruit the patient in 6 months and follow up in 2 months. It is always going to be like 5 years of recruitment and another 5 years of follow-up, or 3 years of recruitment and 2 years of follow-up. So looking at the feasibility, always play with this factors also of study duration and study. Atanu, can you show them one interim analysis command also so that they understand plan interim analysis?
Yeah, just before that, I would like to mention one thing. See, if you conduct any RCT in any other type of disease, like let's say you are talking about the diabetes, you're talking about the cholesterol control disease or skin disease, we never considers much about the study duration. The reason behind that, in those type of study, our outcome of interest is not the event as death. So outcome of interest for diabetes or other studies, skin disease or anything else except oncology studies are that disease under control or not. Okay. So in that sense, we never comes with this scenario that if you increase the study durations, your sample size is going to change over and over. But in oncology, this is the unique scenario where our sample size unit, that is the patient, their number is changes over time because they are going to face the death over the time. So not only the study now individuals, along with their follow-up duration also important here. That's why this unique scenario only raised in sample size calculation for oncological trial where event of interest is death or progressions. So that's why if you increase the study durations, your sample size is going to change. And again, this is the unique scenario happen only for this oncological studies, prospective oncological studies. Eventually, if you work with the, let's say we want to have the toxicity control or not, or that pain or that other stuffs are controlled or not among the patients. In that sense, you are not going to get this kind of study design where if you increase your study duration, your sample size will decline. Only the exceptional scenario in entire kind of study design, statistics applied everywhere, but only the unique scenario only occur here where you can expand your study duration and you can get less number of patients. Yes, so that is my point. So now you're expecting to have, let me have a look with the alpha spending function over there. Let me check where I put it. I think, yeah. And I put it. Yes.
Vijay,
Atanu,
yes.
there is one question.
one
Yeah.
online question has come. Now we are speaking about RCT. Now the one question has come from Dr. Patil that I wanted to analyze large genomic data.
Atanu will take that question after the sample size example. How to analyze
Yes.
large genomic data?
Yes, we will see. So this is another functions available, in GS design as well. So just to run that, this function is applicable with the GSR function. GSR, this is useful, and where you are talking about lambda C. So basically, one group hazard ratio you are going to consider, and that is 0.2. with respect to the another group that is being considered 1. That's mean a reference group hazard ratio is considered 1. With respect to the reference group, this experimental group hazard ratio is considered 0.2. And not hazard ratio, hazard rate. And another is the hazard ratio, hazard rate is 0.5 for the existing group. And again, the eta value is same with the censoring value, that is over 10%. Study duration, total study duration is considered as a T equals to 2, and minimum follow-up is considered as 1.5. So if I run this line, simple line, and thereafter, we are going to get the results. Let me brought this result. So this is some things given that with this alpha spending or the efficacy and futility studies value. So Dr. Vijay already mentioned that Z value and the P value, and with this boundary value, all this stuff. So look on the results. So if it says that if you are having sample size with 460, again with the 33% first interval, we can conduct, because once you are having 33% recruitment of 460 patient sample size, so 33% of 460 value, then we can perform the first interim analysis. Second interim analysis we can conduct when we are having 67% of 460 patients. Then we can conduct the second interim analysis, and final interim analysis we can conduct, or final analysis we can conduct when you are already having 460 patients, those are recruited. Now, corresponding to that, every interim analysis also supporting us, rather than having this 33%, we can also concentrate how many events are being done. So 33, 65, and 97. So if the 97 event, end of the 2 years been done, then we can conduct final analysis. After 1.3 years, 65 event occur, we can do the second interim analysis. And only after 8.8 years, let's say 8 or 9 months later, 33 event occur, then you can conduct the study. So these are basically giving us way when you can conduct the interim analysis. Corresponding to that, what should be the hazard ratio? What should be the efficacy value? What should be the Z value? What should be the P value? That is basically defined here. So if Dr. Vijay already mentioned that the triangle he has shown that. So once the P value is lying between these, then we are okay to pursue the study or to continue the study. If the P value, after having the first interim analysis, if your P value coming within 0.0013 to 0.59, after again second interim analysis, if your P value coming between 0.0054 to 1.17, okay, pursue the study. And finally, rely on the result 0.02 to 0.02. Look, here the P value is aligned from the lower and upper boundary is aligned below 0.05. But before that, for the second interim analysis and the first interim analysis, both the places, the boundary value, basically, this is called boundary value 0.0013 to 0.059. This is called boundary value 0.0054 to 0.17. In this boundary value, anyway, the lower boundary value is fine. It is below 0.05, but the upper boundary is big enough, good, high enough from 0.59, 0.17, and thereafter it lie down to 0.02. So as you see this nicely presented triangle, so see that the difference, the range difference between these boundary value is quite large initially in his graph as well, 0.0013 to 0.594. Slowly, this graph range values goes down, and simultaneously, see in the graphs, both the point has merged. The efficacy and futility graphs merge in one point. Here also the P value is 0.02 and P value 0.02, both point merge together. So that's the way. So here we have to have only one P value that need to be considered, that is 0.02. If your results coming below 0.02 with the P value 0.02, then you are going to accept the results that it is fine. And that's the way it should go. And others way, the first and interim analysis are like that.
Just to
Over to you, Dr. Vijay, if you want to put any
I'll-
other comments.
So just to this Z values and corresponding P values we had talked about. So these are those values. And what he is trying to tell you, so as you go closer and closer to the final analysis, these two tend to merge together. So you could see that this is more 0.028, 0.0228. So are we clear on interim analysis? Any doubts on interim analysis or sample size calculation? Sure? Okay. Manu? Divya? Happy now? Okay. So we'll take the question of large genomic data. Atanu, so the question which has come from Dr. Amol Patil, and I think Dr. Amol Patil, is he online? Can you just check? Acha, he's from the viewing portal. Okay. So the question has come from Dr. Amol Patel is that how do you analyze large genomic data? And knowing Amol, I'm very sure the genomic data would be of gallbladder cancer. So let's say that you have a large 500, 600 genes panel, positive, negative, which has come, and you have outcome data. So how would you go about analyzing such large genomic data?
Yeah, so he shared with me his one Excel file, but I'm not sure how it would be good to open his Excel file here. So
data confidentiality, you
yes, so I'm not going to open it, just I'm discuss it that. See, it is an wonderful area to work with this oncological domain. We are having n number of genes and simultaneously having time to event data. This kind of data is called high dimensional data. What does it mean? The high dimensional data is that you are having, let's say, 300, 400 patient information, and this patient, their age, gender, their different staging status are mentioned. In addition to their duration of survival, like overall survival, progression-free survival, and their event like relapse, progressions, and death being defined as yes or no. In addition to that, there are a number of genomics expression, gene expressions. We worked earlier with this type of data that is 66,000 genes are there. I was looking in his data set. I think it was having nearly 300 genes expressions value, but we are having technology to work with this even it is 66,000 genes. So the fundamental question is that, or the clinical important question is that, out of these n number of genes, which genes are, or which genes expressions are relevant to be considered towards the disease progression or the death. Means if one gene is expression is high, then does it means that this gene is going to penetrate the disease more, or if this of that particular gene expression is low, does it mean that low expression is going to penetrate the disease and the person is going to relapse early or progress early or die early or not? That is the fundamental questions to address for this type of data. So one of the thing is that here it is not possible to proceed with these hypothesis driven methods. You can think that it's a quite contradictory statement, that just before that we mentioned that we should go with the hypothesis driven methods with the primary objective and calculate sample size and pursue the study. But since here we are having n number of genes, it is not permissible to frame n number of hypotheses. So since it is not permissible to have n number of hypotheses, but eventually since we are having n number of genes are also counted with equal number of patients. So earlier in cases, if you are having if you are forming different subgroups of substrata, then you are adjusting with the sample size, because different strata, several subgroups are having different sample size. But here, this is not the case. Here, what happened? Here, number of patients are equal. For equal number of patients, similar number of genes are there, and we are trying to identify which genes are relevant towards the disease progression. So here we have to rely on something called machine learning approach and something called variable selection methods. And these variable selection methods, mostly I'm trying to explain that these variable selections methods takes one by one gene, and by looping criteria, by automation criteria, it's try to find out the gene is relevant towards a disease progression or not. Once that is done, then it's throw it, and then it's take another gene, and it's again try to find out that second gene is relevant over there or not. Simultaneously, it's keep on take one by one genes, and it goes up to 66,000 genes. And out of that 66,000 genes, it's try to find out which genes are relevant, and what about the pathways analysis. That is called pathways analysis. Gene network formations are there. So that's the way it need to be considered. One remark that I have noticed, I'm not sure Dr. Amol is here or not. One thing is that in that data set, I have noticed the many places is being considered as a zero value. So if it is a zero value, then we commonly discard those expression value or those patients value. If you are putting this zero value as not expressed value and some value as expressed value, so basically you are going to make those genes value as yes or no formations, means dichotomize the value. That is okay, because EGFR also we make as a positive or negative. So that's fine, good enough. So to make the genes as a dichotomous formation, still the mechanism is initial mechanism is to pursue the variable selections methods in that aspect. So yeah, so there are in addition to the variable selection methods, there are classification mechanisms are there, and other stuffs are there. So just last week I submitted one of my next my book chapter with big data with oncology, and this book is going to be published from CRC Press. Once it comes, I'll be happy to share with you guys. So there I only dedicated with this high dimensional data and this in oncology, how to work with the high dimensional data and variable selection mechanisms, different way to finalize these relevant genes, and they should be control on the disease progressions. That's been there. So once it is done, I will share with you. But yeah, that is a completely different new techniques, new all way to go new directions, and that is completely different from the sample size calculation and clinical trial aspect as well.
Thank you, Atanu. Anyone has any other question? Any question anyone has? Okay, so Atanu, no more questions. And there was one question which has come online, which not for stats, but it's kind of a in general question has come from my friend Prashant Mehta. He wishes to know viable funding sources for investigator-initiated trials in India. Now, the thing is that whenever you write a trial, especially investigator-initiated trial, it's your headache to get the funding. So, but the best way is that you convince your institute to give some amount of seed funding. So that's called intramural funding. Tata gives that, so it makes our job very easy to do studies in TMH. The second source of funding is ICMR, ICRC. The third source of funding is something called SERB. It's SERB, you just Google SERB. SERB is a Scientific Energy Research Advisory Board, which also gives funding.
By DST.
DST gives funding. Apart from that, Wellcome Trust DBT actually gives a call every year in January for clinicians, which gives an early fellowship or internet fellowship or senior fellowship and a Margadarshi fellowship, which range from 1.7 crores going up to 7 crores. So you can apply for that. So these are the sources of funding. In addition, you can actually also take funding from pharma for your studies. For example, there are investigator initiated sponsored studies, which are like if you approach MNCs like BMS or MSDs or Pfizer or Sanofi, they have a program that if you are trying to work on their molecules, you can ask them whether they are running a such program 6 monthly at least once in a year. This program is open with MNCs where you can send your concept sheet to them, and if they most of the time it's a global competition, and if you get selected in that, Tata Group, our group has got twice or thrice such kind of fundings. If you get selected with that, they will completely fund your trial. Also, the drug, because you are going to use their drug, the drug will also come free of cost. Another source of funding is that you can actually uh, try approaching NGOs and philanthropists for investigating shit. But this, I would suggest to approach after you build up your CV with a few studies, because that would require a lot more amount of convincing to be done. The next question is, in what situation DCGI clearance is not required? Basically, DCGI clearance is required if you are going to market the drug. If you're not going to market the drug, investigative studies, you don't actually require a DCGI clearance per se. But for pharma, it is a new drug or a new schedule or a new indication or new preparation, the DCGI clearance is required. Most of the times, what is said is for investigator initiated studies, you need to notify the DCGI. DCGI actually gave it a 2 years pre-COVID, so that was 3 years back, has given a notification that the IEC, if feels that this investigative study needs a DCGI clearance, they should notify the DCGI within 1 month. If the DCGI doesn't revert back, it is to be assumed that the DCGI has cleared your study and it is not required any go ahead. If DCGI puts a query, then you are liable to now answer the query, and to their satisfaction, they would either consider the DCGI study or not a DCGI study. It makes hell of a lot of difference if it's a DCGI considered as a DCGI regulated study, which means that every essay and every event which happens in the study also needs to be notified to the DCGI. The last is how compensation clause is taken care with limited available funding. Now, frankly, compensation clause cannot be taken care by limited available funding. At Tata, what we do is that we have an insurance cover which covers for compensation for all studies which are investigating initiated. Those of you who are planning to do the study, I would request take an institute broad umbrella kind of insurance which will take care of compensation clause, because taking an insurance for every study in the name of a PI is not only not cost effective, it's also a headache also. Those were the questions online. Any other question is there? Just have a look. Okay. Thank you, Amul. Yeah. So with that, thank you, Atanu. I don't know, I didn't actually officially introduce Atanu. Just the end part of the discussion, but let me introduce Atanu. Atanu is actually a dear friend of mine. He's a PhD in statistics and is actually an authority in Bayesian statistics. He was in Tata for since up till last 6 months now. He has parted ways with Tata Memorial Hospital to do more bright things in future, and we wish him luck. Okay, and that's it. I am Vijay Patil. Most of you may be knowing me. If you don't know me, that is also okay. With that, we call it an end to the statistics workshop. If anyone has a question or was feeling shy to ask the question, you can ask the question now. So okay. So what? Yeah. So okay. So we have been getting a very good response to statistic workshop, and uh, under the cancer it's a statistic foundation under which the conference run is actually a group mainly by young and budding medical oncologists like Manu, Ashay, and people, and they have been good enough to include academicians like us also. So under their guidance, we will be planning a statistics workshop, and that would have limited entry of only 10 to 15 candidates, and the financial aspect will be taken care by CRSF itself. So if any one of you are interested, we'll be sending the flyers in a few months from now. So see if you can attend, but that would be an extensive workshop only for 10 to 15 candidates with 1.5 or 2 days of grilling, so that you at least you get some hands-on with statistics, and that would be much theoretical. That would be more thing like practicals, like the way Atanu showed you the commands. Those commands will be given and you will be made to do the analysis. So if you are interested, those who are watching online also will be sending it to all people who registered for the meeting, and things will be open on the CRSF website also. That's it. Any question? If anyone has changed its mind? No, then we'll call it a day, and most of you are invited for dinner, and Atanu can go and rest wherever he is. Thank you, Atanu.
Okay.
Bye.
Bye then. Thank you for all this effort, Dr. Vijay and Dr. Ashay. Have a nice dinner. Okay.
I make sure always I have a nice dinner.
Yes. Okay.